Good morning, everyone. Let me introduce my PhD thesis, which is the impact of new genomic technologies on patient care. My name is Csendes. I'm a clinical geneticist, and I work at the Institute of Genomic Medicine and Rare Disorders. My vision is to boost the effective utilization of genomic technologies, and my mission is to recommend, develop, and support educational and financial policies. And to achieve that, I have two ongoing projects. My first project is investigating the functional ability of patients before and after Spinraza treatment in spinal muscular atrophy. Spinal muscular atrophy, SMA, is a progressive hereditary neuromuscular disorder resulting from the loss of the SMN1 gene, which leads to a severe muscle weakness and atrophy. Without adequate treatment, it can be lethal under age of 2. So no wonder it is the most common genetic cause of infant mortality, with an incidence of approximately 1 in 10,000 live births. Fortunately, within the last few years, 2 disease-modifying therapies, Spinraza and Evrysdi, and 1 gene therapy, Zolgensma, have been approved for use in SMA. Within our initial project, we will exclusively concentrate on Spinraza, as a significant amount of eligible data is only accessible for this medication. Approved in 2016, Spinraza became the first therapy for SMA. Administered via intrathecal injection, it is a lifelong and extremely high-cost therapy. There are 4 types of SMA based on the onset of the disease and the severity of the symptoms. Alternatively, SMA can be divided based on the functional abilities of the patient at their time of their diagnosis, namely non-sitters, sitters, and walkers. Previous meta-analyses used the traditional classification. However, we would apply the aforementioned groups because it correlates better with the outcomes to be examined and reflects the variability in therapeutic response in a more efficient way. So our aim is to investigating of the effectiveness in patients with SMA with different functional abilities. Which leads to our clinical question: how the functional ability of the patients with SMA influence the effectiveness of Spinraza? To answer our question, we set up a PICO framework. Our population is non-sitter, sitter, and walker patient. Our intervention is after Spinraza treatment. Our comparator is before Spinraza treatment. And we would like to measure effectiveness and safety. Our hypothesis is that the clinical effectiveness of Spinraza significantly depends on the functional ability of the patients with SMA. With our study, we would like to highlight the importance to classify and treat the patients according to their functional abilities. We conducted our systematic search in 3 databases. Here you can see the finalized search key for that. After the selection process, we ended up 17 eligible full text. We analyzed all of our planned outcomes, so let me introduce the results of these. On the first forest plot, you can see the 1-year change in motor function based on the Hammersmith Functional Motor Scale. This scale assesses the patient's ability to perform different activities, total score ranging from 0 to 66, where 66 means that the patient's ability resembles that of a healthy person, and 0 indicates poor motor condition or inability to perform any activities. For the statistical analysis, we used mean difference. In the walker subgroup, the mean difference was 2.99, and in the sitter subgroup, the mean difference was 2.57. Although the effect of Spinraza is small, it is clinically relevant for the individual patients. Another noteworthy conclusion is that the functional ability does not impact the drug's effectiveness. On the next forest plot, you can see the 2-year change based on the same Hammersmith Functional Motor Scale. The mean difference was in the sitter subgroup 1.64, which is approximately the same, or a slight decrease can be observed compared to the 1-year result, which can be expected due to the natural course of the disease. The results are not statistically significant, so we will need more data to support our statement. On the third forest plot, you can see the 1-year change in motor function based on the revised upper limb module. This scale assesses the patient's upper limb function. Total score ranging from 0 to 37, where 37 means that the patient's functional ability resembles that of a healthy person, and 0 indicates no upper limb activity. For the statistical analysis, we use mean difference once again. In the walker subgroup, the mean difference was 0.33, which is not clinically relevant, and in the sitter subgroup, the mean difference was 1.03, showing a clear tendency for improvement. With additional articles, the mathematical significance may emerge. Although a 1-point change might seem insignificant, for a patient it means that they are able to raise a cup to their mouth. Without any treatment, the patient's condition would deteriorate, so any improvement is considered as a success. Of course, our study has its strength and limitation. One of our strengths is the detailed subgroup analysis regarding the non-sitter, sitter, and walker division. On the other hand, this is our limitation as well, because due to the different classification in previous studies, not all data can be, unfortunately, assessed. Based on our results, Spinraza has proven to be efficient in the sitter and walker subgroup, so therefore clinician can indicate Spinraza therapy for sitter and walker SMA patients. Future researches might consider applying the alternative classification more widely. Here you can see the progress of my first project. We are currently working on the manuscript, and on the next slide, you can see the status of the manuscript writing process. Moving on to my second project, which is investigating the effect of approved treatments for spinal muscular atrophy on the patient's healthcare needs. Before the era of disease-modifying therapies, best supportive care was the gold standard for spinal muscular atrophy. It is a comprehensive approach that aims to address the various aspects of the condition. The key elements are nutritional and respiratory support, orthopedic care, and rehabilitative services. I already introduced to you the approved treatments in SMA, Spinraza, Evrysdi, and Zolgensma. It is important that today's days, treatments must be provided alongside the best supportive care. Managing the symptoms of SMA often requires a large amount of healthcare resources. So there's healthcare needs of SMA patients include individualized supportive, rehabilitative, and palliative care, which comes with a substantial cost. Unfortunately, there is a limited information of healthcare resources utilization. However, it would be essential for adequately designing public policies and funding decisions. Our aim is to investigate the effect of addition of Spinraza, Evrysdi, and Zolgensma on healthcare needs compared to the best supportive care only. Our clinical question is, how does the addition of Spinraza, Evrysdi, or Zolgensma influence the healthcare needs compared to the best supportive care only? We would like to compare best supportive care to each and every approved treatment to best supportive care only. And we would like to measure the healthcare needs of SMA patients. Our hypothesis is that the addition of Spinraza, Evrysdi, or Zolgensma significantly reduced the healthcare needs compared to the best supportive care only. And hopefully, my two projects will contribute to address the different dimension of treatment impact and allow me to finish my presentation with Peter Drucker's words: the best way to predict the future is to create it. Thank you so much for your attention.
Thank you very much. Congratulations. It's a really impactful work.
Thank you.
These patients suffer a lot because of their severe disease.
Yes.
And I was just wondering, in the area of Zolgensma, has other treatment regimes any role in the future, or it will just eliminate those treatment options and Zolgensma will be the final treatment strategy there?
I mean, currently, I think we administer more Spinraza to the patients than Zolgensma. So actually, we exclusively treat the patient with Spinraza at our institute. And I think because we also treat the adult patients, not the children. I think when we will be able to test the patient early on, actually pre-symptomatic, there will be a higher chance to Zolgensma will be more widely distributed throughout. So I think there's a tendency for using Zolgensma a little bit more, but currently, actually, I think the tendency is that we are that Spinraza is a little bit more common, actually.
Are there any data about survival based on the Spinraza in those patients? Does it prolong survival in those patients?
At this point, we don't know yet because it is only approved in 2016. So we only have 1 and 2 year data available. So at this point, we cannot tell. And previous studies does not focusing on overall survivor, only just focusing on, the motor function. Yes.
I mean, your data are amazing. They show clear, trend towards the Spinraza, but it's already approved that it's suitable for those kind of patients. But in the clinical practice, isn't it like the number 1 option therapy for those patients?
You mean Spinraza?
Yeah.
I think it is the number 1. It's depending on the patient's type and which kind of therapy would you choose, and also the copy number. SMN copy number is also a contributing factor to that. So it depends which medication can I choose for these patients. So mainly because we only able to test these patients with symptoms. Usually we are able to give them Spinraza. But nowadays, as pre-symptomatic screening options are more common and more widely used, we are able to use Zolgensma a little bit more often.
All right. And are you aware of any adverse effect of this drug?
Not serious one, just there's no any serious side effect, only because it is an intrathecal injection, are only these kind of effects that they have, side effects.
All right. Yes, we have a question.
Thank you for your presentation. I would like to ask, how did they measure the functional improvement in the different studies? Was there any specific way to measure the improvement?
Yes, thank you for your question. So they use these kind of functional motor scores. So the Hammersmith functional motor scale, revised upper limb module, and there's another ones as well. But usually for SMA type 2 and 3, we use these 2 types of functional scores.